Morning everybody. Hopefully we are all good. Always a bit nerve-wracking when we get back after a couple of weeks off. Looks if we've got some people live. If you want to pop us a message in the comments just to make sure that everything's working okay, and then we'll get going. Just get rid of that. There we go. Happy New Year. So it's yay, Becky's here. Good. So yeah, we're back. 2024. Here we go. Another round. Merry New Year to you, Tris. Good to see you guys again. Yeah, it seems like ages since we did the last one. When was it? It's kind of like it was just before Christmas, wasn't it? So yeah, around about the 18th, probably something like that. So it's been a few weeks, which is it's been quite nice having a bit of a break, having a proper break this year. Right, Stevie, good to see you there, mate. You all right? Okay, let's get going. So this is where we finished up last week or last time. So we were looking at the compartments of the thigh, and if you've not heard about this before, it's very similar to the compartments of the leg, so around the shin kind of area. And you heard of compartment syndrome in that area. It's quite, I say it's quite common. It's something that's commonly taught, but not so much in the thigh. We don't really hear much about compartment syndrome in the thigh, but it can happen. Hey Penny, Happy New Year, thank you. Yeah, so obviously if you have an injury to any of these muscles or any of the vessels, and they're within these compartments that are surrounded by connective tissue, then it's exactly the same as the leg, where the fluid, whatever it is swelling, whatever it is not going to be able to escape. So can create a major problem. Hey Martin, good morning. Glad you made it. Happy New Year. Looks like we've got a few of the regulars in this morning. That's good. Cool. So and it's just something to be aware of. I think, especially if you work like sports therapy pitch side, physiotherapy pitch side, and somebody has some kind of impact injury, or you think they might have fractured their femur, then there's a risk of that developing into a kind of thigh compartment syndrome, just as you would have that fear in the leg if there was an impact in the leg. Quite often it's described as one of those things where it's a really rapid onset because of a bleed or the swelling, and usually excruciatingly painful. So that it's one of those where it's a hospital job. Okay, so just something to have in the back of your mind with this region. Again, I don't remember ever being taught about this on my original courses, but obviously since sort of looking into things in a little bit more depth, then you realise that these things can happen, just not commonly discussed. So yeah, we talked about these septums here. So we've got the femur here, and then we've got a septum here. So medial intermuscular septum just there, and then that links up with this white line around the outside. So this is your fascia, and then we've got a posterior intermuscular septum that then connects into the femur, a lateral one here. Okay, so that one there that connects into the femur. So I described it, which was perfect for Christmas time, like a Trivial Pursuit pie with all the pieces of the pie in, but obviously we don't have as many. We've got this big area here, so that's one piece of pie, and then this one here, and then this one here. So we've got three cheeses instead of six, but it's that kind of, if you imagine that from the top down, that's basically what it is. Okay, so you're kind of in those compartments. When we do dissection to this area as well, you can there's clear fascial divides between these regions. So we've already had a look at this region here. So this is the anterior compartment. We're going to do a little bit of a recap of some of these. We had a look at some of the muscles on the lower part of the leg as they're coming up over the knee. So gastrocnemius, popliteus, that kind of thing. But we're going to have a look at some of the other muscles coming from the hip down this time, and we'll definitely, we'll recap these ones. We'll recap these ones as well, and then we may be able to get to the posterior compartment. We'll see how we get on. There's some really cool stuff going on in this medial compartment. So this green area here, and if we have a look at some of the muscles, you've got gracilis, and we've already talked about gracilis before. We looked at that with sartorius, so they were both linked together on the video, but they come from different compartments. Okay, so we've had a look at sartorius up here, and we'll have a look at gracilis again, and then we've got this one here. What's that? Yeah, there we go. So that's adductor longus, just attaching in there, and then this massive muscle here, adductor magnus. So magnus means vast, means really big. So we've got this really, really big inner thigh muscle that acts kind of, well, it's like your fifth hamstring, we call it, because of the attachment points. And when it contracts, depending on the position of the limb, it can generate force into extension of the hip. So it is like another hamstring muscle, this adductor magnus. And there's a really cool relationship with adductor magnus and the blood supply that goes down to the leg. So we've obviously already covered that when we've looked around the shin and the calf and everything. And we're going to have a look at how you get your blood from your hip down into past your knee and then down into the foot and ankle. Tap it. Oh, there is a little bit of a tap on there. Hold on. There we go. That might help. Thanks, Tris. It was resting up against one of my lights. Sorry, mate. Right, let's have a bit of a recap. Yeah, so we've got anterior compartment. Let's just get rid of that. So we had rectus femoris. So let's just go over this one again. Yeah, let us know if the sound's better on that, mate. So here we go. So this is rectus femoris, so part of the anterior compartment, the one at the front of the thigh. And all good, thanks. So this is, this one just here. Let's just pause that. So this one just here, the most superficial of your quadriceps muscles, so the ones at the front. So depending on what kind of level of anatomy you're learning, you'll go into different depths of these muscles. So for like level 2 gym instructor type courses, you'll usually learn the front of the thighs, the quads, and you don't really learn that there are that there are 4 quads, but you don't really learn the names of each of them. So if you're at that level, this is part of the quads, and this is one of them. But there are more than 4, which is a bit annoying because it's not so simple as that. But this one, rectus femoris, is one. So if you're dealing with sports injuries, especially, very commonly injured because it crosses 2 joints. So it crosses the knee and it crosses the hip. And if you remember, we were having a look at some of the attachments up in the hip here, and there's a little there's 2 attachments up in the hip of rectus femoris. So let's just have a look through this one. So you got vastus lateralis on the side, and then this is your rectus femoris just here. So let me just pause that there. So there are 2 heads to it. So you can see that strip of muscle just there. That's your rectus femoris as it comes up into the hip, and it attaches onto your AIIS, which is your anterior inferior iliac spine. So just underneath this bony prominence just there, which is the ASIS. So that's quite easy to palpate. And then just underneath that, that's your AIIS. So if you are suspicious that someone has strained their rectus femoris and it's a high like tendinopathy, then you can palpate around this area to see if it reproduces their symptoms when they contract the muscle whilst you palpate that region there. Okay, there are some other muscles overlaying it, so it's not really 100% accurate. But if you're doing things like diagnostic scanning, that kind of thing, then it can be very, very accurate, because you just drop off that ASIS and then you know you're on the rectus femoris, and you can see the front of the hip socket as well. And then this bit here, we've got the supraacetabular groove. So supra means above, acetabulum is your hip socket, and there's a little slip of rectus femoris that comes off and then just attaches just above your hip socket. Okay, so it's not just onto that AIIS. Again, this is where you go into the intricacies of it. So kind of level 4, level 5, it's AIIS, just like on this. So that all of this information here is taken from the Complete Anatomy app. Yeah, so I've just copy and pasted that information into there. So that's what it says in the app. But actually, there's a little slip that comes off that goes into the top of the acetabulum as well. So again, even with the apps, even with the book, so the trail guide book, that will tell you AIIS. And yeah, it's not just the AIIS. There are some other bits that it attaches to as well. So there you can see it there. You can see that hip. So obviously we'll cover the hip as we go up the body a little bit more. So there's your two attachments at the top, and then it comes down and attaches into your tibial tuberosity. So just below your kneecap. So there's your kneecap, just there. There's your quad tendon, vastus medialis, just on there. See, sometimes, let me just pause that. So sometimes this area here is called VMO, so vastus medialis oblique, because the muscle fibers are orientated in an oblique direction, so they go diagonally. Okay, so that's these ones just here. You can see this one here. This is your vastus lateralis. So on the outside, so lateral, lateralis, medial, medialis on the inside and outside, and then there's your rectus femoris in the middle. Okay, so these all form part of your quadriceps group, and then there's the quad tendon just here. And what I find again, so if you're dealing with sports injuries, runners, anybody who's, well, doesn't have to be a runner, but it can be anybody, but you can get tendinopathy issues in the quad tendon, so around here, as well as the patella tendon as it attaches into the tibial tuberosity down here. Okay, so your kneecap, your patella, is under there somewhere. All right, and so it's just encased in the quad tendon. So a tendinopathy can occur anywhere around there. Cool. So that's rectus femoris. So that's that one there. So you can see it's not as clean as the images in the apps as this one here. There's your patella, and then there's the attachment there on the tibial tuberosity. So that's your rec fem. And then if we have a look at the vastus muscle, so vastus lateralis we've had a look at already. You've just seen it on that video. Obviously on the video, I think that person was probably quite old. Their muscles are quite small, and usually some of I mean, it depends on the kind of cadavers that you see, but yeah, if you usually when you're feeling people that are alive and you're palpating muscles of people that are alive, they're a lot bigger than what you've just seen on those videos. Okay, so that they are quite elderly, I think, those ones. So that's your vastus lateralis. Vastus medialis is here, so this is the VMO. So vastus medialis oblique, and again it's attaching into that quadriceps tendon at the top of the patella. So you've got the quad tendon, then the patella, and then the patella tendon underneath. Okay, so the it's a bit weird because it's not like a normal tendon, and there's been debates about how to rehab it, because if you think about like the Achilles tendon, it goes from muscle to bone. So you've got the gastrocnemius, the soleus, into the Achilles, and then into the calcaneus. So not nice and simple. Whereas in the knee, you've got quads into the patella, and then there's no muscle then between the patella and the tibial tuberosity. So even though it's tendon, it's not like a normal tendon because it's got a blooming great big bone in the way. Okay, so there's been, like I said, there's been lots of debates about how to rehab it and whether you can rehab the knee the same as the um, gastroc and the Achilles, because they do two different things. So the Achilles is a lot more of a spring-loaded tendon, whereas the patella tendon isn't like that. So yeah, good person to have a look at. Pete Maliaris is a good one. So he talks about and Jill Cook. They're both from Australia. They talk about the different ways to rehab these tendons, and you can't just lump them all in together. Okay, so but that's evolving as well. So you'll go, yep, isometrics are great, they're the best. Then it'll be eccentrics that are the best, and actually is probably a bit of a combination of everything. Okay, but there we go. This is your intermedius. So this is in between your vastus medialis and vastus lateralis, and underneath rectus femoris. And this is the last one that forms the quadriceps group. Okay, so these are all your quads. So let's have a look at those. Hopefully it's this one. So we've got medialis and lateralis, but we don't have intermedius on the dissections. So you've just got those images that we showed you before. So there's your medialis, vastus medialis oblique. There's the lateralis on the other side. And then, like I said here, huge muscle attached onto the posterior femur. So it comes all the way back here. So sometimes when people are complaining of discomfort on the back of their femur, you might assume that it's a hamstring issue, but your vastus lateralis and vastus medialis both attach onto the back of your femur. So it's really, really difficult to through palpation and through location to be able to discern whether it's one or the other if it's around that kind of area. Okay, but by palpation alone, especially because you've got this big white line on the back of the femur, the linea aspera, which we should see. There we go. So there it is around there. So that's where the lateralis attaches. Okay, all around that area there. So there's the linea aspera, basically means white line. And then there's the medialis attachment. So it's right round the back. Okay, so they basically wrap around the whole thigh from the front to the back and then attach onto the femur there. And then you've got your hamstrings over the top of those as well. Okay, so it just gives you a sense of the depth of the different structures. So that was those. Then we had these little muscles. So articularis genius, which we talked about this last time, and attaches onto the top of your suprapatellar pouch, which is a part of the joint capsule. And there's a bursa right at the top, so around this area here. So it's a fluid-filled sac that helps to reduce friction of the patella rubbing on the femur. And what articularis genius does is it contracts when you extend the knee to move that pouch out of the way so that it doesn't get pinched. Okay, genius. Okay, absolute genius that is. I've never seen one in a lab though. I think they're probably dissected away maybe, or they might be like really, really small. I've never been able to see one. I'm going to the labs on Saturday coming up, so that will be on my list of something to see if we can find it. Makes me wonder, all those saying they have tight hammies. Yeah, exactly. Yeah, because it's just that kind of region, isn't it? And there's so much going on in that region. We just assume it's the hamstrings, but there's lots of other stuff lots of other stuff there as well. But yeah, so if that's a point, we do still have spaces available this Saturday if you want to come with us to Kiel University and have a look at the specimens there, and come on the hunt for an Articularis genus with me if you are not doing anything else. Cool. Right, we've covered that one. Let's jump forward a little bit onto the medial. Here we go. Cool. So, reason I've skipped over Sartorius is because Sartorius and Gracilis are lumped together, and we'll have a look at Gracilis this time. So it will combine the two. I'm just going to go back a little bit to that. Okay, so we've had a look at this region here. Okay, so that's all your anterior compartment. And then we're going to move on to this one here, the medial compartment. Now, the muscles are important, obviously, but I also want to bring to your attention these vessels as well. So we've got deep femoral vessels here. So around your belly button area, you have your descending aorta, which is one of the biggest blood vessels coming out of the heart. And around your belly button level, which is about L3, it splits into two, and it splits into iliac arteries. And they're called iliac arteries because of the region that they're in. Okay. And then as it splits and it goes down the leg, it then divides into other vessels. But one of the main vessels for the leg, as it crosses over the hip, it becomes the femoral or femoral artery. Okay. And that's the one we're interested in. And it's exactly the same vessel. It's just called something different as we go down. But this area here, that this is the structure of the muscles has an impact on the pathway of this vessel. Okay. And again, if you're dealing with like quite severe injury, so if you fracture your femur and you basically burst the femoral artery by cutting it with the kind of jagged edge of the bone, that's a medical emergency. So knowing where the blood supply goes and how to stop that blood supply if there is a major problem is really key if you deal with pitch side trauma. Okay, so we're going to kind of go over a little bit of that now. Here we go. Okay, cool. So one of the main muscles that we need to look at is this one here. So this is your adductor magnus, which is considered to be your fifth hamstring. And you're thinking, hold on, there's only three hamstrings. Well, you've got biceps femoris, which has got two heads, then semimembranosus, semitendinosus. So those are your four, okay, but obviously two in one. And then the adductor magnus is the fifth, okay. So it's considered to be part of the hamstring group, but also the adduction group, okay, so the adductors as well. So it's coming up from here. We'll talk about the pubic insertions when we get to the hip. So we're interested more here. So it doesn't cross the knee joint, so it won't do anything to bend the knee. Okay, that there's no attachment onto the tibia, so your adductor magnus won't bend the knee back. Yeah, there'll be no flexion at the knee. But it's got massive attachment onto the femur there, and then we've got this hole just here. Okay, this is called the adductor hiatus. So there's basically a hole for the blood vessels from your hip to pass through to get to your lower leg. Okay, so if remember I was saying about the iliac arteries where they split. And then when they come over here, when they come over this pubic bone, they turn into the femoral artery. They then run down the front of these muscles here, or this muscle in particular, and then they pass through that hiatus and go through it to the back. And then that, obviously you won't be able to see it there, forms then the popliteal artery, which we'll have a look at in a bit, but we've already seen that on the last section as well. Okay, but as it splits into the the tibial arteries. So yeah, that's the origin of that vessel. Okay, so it comes over here, over the top of this muscle and some others as well. We'll have a look at that in a sec. Through this hiatus, round the back, and then supplies your leg. And there's only one vessel. So if there's any problem with it anywhere along that line, it will knock off your blood supply to your leg, which is, it can be a good thing as well, because in a first aid situation, an emergency situation where you're losing a lot of blood, you only have to put pressure on one artery to stop the blood flow to the leg. Okay, so so that can prove quite useful as well. If you have a look here as well, this is quite interesting. So the nerve supply, and again we'll cover this as we go through. We've got the obturator nerve, which supplies the medial compartment, and then we've got the tibial part of the sciatic nerve. So that's interesting. Okay, so it's got two nerve supplies, and this is why we call it or part of the hamstring group, because the sciatic nerve supplies the posterior compartment and the rest of the hamstrings, but also a portion of your adductor magnus. And the obturator nerve, which is part of the medial group, which adduct the leg, so bring the leg in. Okay, so that's why there's that's why it's considered to be part of the hamstrings as well. That's right. Yeah. Considered fifth hamstring due to its ability to extend the hip. Yeah, exactly. Yeah, and it's because of where it attaches. So if you have a look at the attachment points here, so all of these ones along here, because you see the orientation of the fibers, so they're gonna adduct the leg, whereas this one here is straight down, so it's a bit more like a hamstring. And if the angle is right, then it will extend the hip. Yeah, that's right. No probs. That's cool. Cool. Good. So that's that. Let's have a look at this. So we've got two parts to it. Let's go for this bit first. Okay, let's go this bit first. So this is the magnus. Okay, just pause that there. So this is the image from the trail guide, and it kind of splits it into two muscles. We've got these kind of portions here, this portion here, which will the orientation of the fibers is more adduction, and then these fibers here that are more sort of straight up and down, which is more for extension. Okay, so this area here will be supplied by the obturator nerve, and then this one here will be supplied by the sciatic nerve. Okay, so we've got two nerves operating the same muscle, and depending on what action you need will depend on which one kicks in. So, and you can see on the cadaver, although there are different orientations of fibers, it's not as clean as this. Okay, so it is a bit all over the place. And then we've got this big bit of connective tissue, and then so a tendon all the way down to here. So this is the supracondylar area of the medial part of your femur, and that can be really, really tender as well. Okay, so you can have a feel of the lateral epicondyle, and then you can actually get onto that area. It depends on the muscle bulk of someone, but you can get into that area and have a bit of a palpate around there. It's usually quite tender around that spot. But we've got a couple of other muscles that pass over this area as well. Okay, so you've got the gracilis that goes quite close but attaches just a bit further down. But the main area we're interested in is this bit here. So this is the adductor hiatus. So the blood supply will come down here, rest on top of that bed of muscle, massive fan of muscle, and then it will drop through that hole and then go to the back of the knee to form the popliteal artery. So let's have a look there. So here we go, adductor magnus, adductor hiatus, and then you see it from the back. So it will come, that's where the blood supply will come through. Okay. Excuse me. So again, view from the back. This is a great dissection. And then you see all the, I'll just do that one again. That deserves playing again, that one. There we go. So we've got two distinct direction of fibers, not so distinct on the actual cadaver, but you can see as it passes through. So they pass the knitting needle through, and that's the direction of your femoral artery there, and as it comes through there, and then becomes the popliteal artery. But it's a massive, massive muscle, huge muscle, this one, hence the name. Okay, so it's adductor, adduction, and magnus means massive, basically. That's a good question. Yeah, cadaver's got a couple of additional hiatuses higher up, not shown on the drawing. Is that normal? Yeah, you often see those. Yeah, there's sometimes they're there, sometimes they're not there. Yeah, just in this particular cadaver that they were there. Yeah, this is the thing. You see lots of different anomalies. So there may be blood vessels that pass through there for that particular individual, and it's just formed that way. Yeah. Cool. Let's have a look at the next one. Yeah, so then we've got longus, and longus is part of the medial compartment, but brevis isn't. So we'll talk about brevis and longus in a bit more detail when we get to the hip, because they're considered short adductors. So they literally just kind of they're around the hip region. Okay, but because this is part of the adductor longus is part of the medial compartment, we'll include it here. Okay, so adductor longus means long, and it's an adductor. Anterior surface of the pubic body, so similar kind of region to the adductor magnus, but a little bit more anterior. Okay. Again, attaching on the linea aspera. So we've got another attachment on that white line at the back of the thigh. So that is, again, like Stevie said earlier, people assume it's hamstrings, but we've got another, and the magnus as well. If we go back to magnus, so gluteal tuberosity, medial supracondylar ridge, and adductor tubercle down here. So again, we're really, really close to that linea aspera line right at the back. Okay, so we've got that muscle there. We've then got the longus on top of that, which is then attaching onto the linea aspera as well. You've got your vastus medialis, vastus lateralis attaching around the back as well. So all of these muscles that are medial, or you would consider to be medial and anterior, they attach at the back. Okay, so again, it's sometimes it's obvious what the problem is, but sometimes it's not. So adduction of the hip. Okay, so there's no, and the reason why this is an adductor and not considered an extensor is because of the attachments. Yeah, so if the orientation was down here, then you could get a line of pull to be able to pull into extension. But because of the orientation of the fibers, it may assist, but it would be very, very weak. Okay, so that's why the adductor magnus, because it attaches down here, and because of the sciatic nerve innervation, that's why it's considered part of the hamstring group as well. Cool. Right, let's have a look at this one. So this is brevis and longus. So we're mainly interested in longus in this one because of the medial compartment. So there's your, just get that there. Okay, let's just go back a bit. Skipped quite a few then. There we go, just pause that there. Ooh. Lock that in place, hold on. Okay, so you've got your femur, greater trochanter, lesser trochanter, you can just about see there. Adductor magnus, adductor hiatus. So that's what we've just been looking at. Okay, so if we then add in, here we go. There's brevis. So it's a really short muscle. It's brevis and pectineus are the ones that usually get injured in footballers, people who or play sports that change direction quite quickly. So these short adductors here. So that's adductor brevis. Brevis means short. Longus means long. So let's have a look. There we go. So you can see brevis just there. Okay. And then longus, which is the one we're interested in right now, is this one here. Okay. And you can see magnus just behind it. So they form like a bed. Okay. Like a sheet for the blood supply to rest on the top of. Okay. And we'll have a look at that in a second. So there's longus, and there's your attachments. So right by the pubic bone. And again, this is one of those things where you may it's like a groin injury. Yeah, so if they're pointing to the groin, there's usually an adductor injury. But around this area as well, when we start to have a look at this region in a bit more detail, in males especially, because of the spermatic cord going into the testes, you've got an opening which can cause a herniation. Okay, so we've got a risk of a herniation around here as well. So you can have what's called a sportsman's hernia, which is a muscle problem, which are these ones, or a hernia, which is a guts poking out of where they shouldn't be problem. Okay, so we'll talk about those in the inguinal region when we get up to the hip area here. So we've got brevis attachment there, longus attachment there. And again, these ones, along with pectineus, which we haven't looked at yet, we'll look at that when we get up to the hip. It's usually pectineus and brevis that are the ones that are a problem with footballers. Okay, or like I said, people who play sports where they change direction. And then there's your attachment at the back. So there's your magnus attachment. And then there's your longus and brevis. So again, we've got another couple of muscles that are attaching around that linea aspera. Okay, so that white line on the back of the thigh. People's perception of palpation totally destroyed by the layering of muscles. Yeah, and that's the thing. I mean, how the how the heck you can tell of what you're. I mean, if you push on the back of the thigh here, you're going through hamstrings, quads, even though it's at the back, plus your adductors. Yeah, all of those attaching. So adductor magnus, brevis, longus, vastus lateralis, vastus medialis, plus your hamstring group over the top. Short head of biceps attaches around there as well, all in that region. And you go, oh yeah, it's hamstrings. It's just insane. It's really hard to tell for sure. So that's where accurate diagnostics come in. But then also with that, it doesn't really change what you do. Yeah, I think it just changes the narrative. So if it's a muscle problem, then you treat it in a muscle way, and it will recover in a muscle amount of time. If it's not recovering and it's not going the way you think, then you need another opinion. It's not really going to change what you do, whether it's the adductors, the hamstrings, or part of the quads, because you wouldn't just isolate certain areas anyway around that kind of region. You would treat the region as a whole. So it just matters about the story. So and that because the story can freak people out if they think they've got a problem in an area where they don't really have a problem. So that there you go. So there's your longus, there's your brevis, magnus just behind. And then, your longus stops just above the adductor hiatus, which is where the that blood supply comes through. So there it is coming down there. Okay. And that leads us on to the last bit for today, which is this one. And this is the adductor canal. Okay. So kind of bringing all that medial compartment together. Here we go. So there's your vastus medialis oblique. Let me just pause that there a sec so we can get some orientation. So there's a lot of meat here, okay, trying to work out what bit's what. So this is a right leg. Up here is where the pubis will be. That looks like rectus femoris just there. That's vastus medialis. That looks like your quad tendon just there. Adductor magnus just there. Okay, so you can see now how the quads and the adductors all kind of fit together. Adductor longus just there, adductor brevis. And then this is the adductor canal. Can you see that groove there? So there's like a groove that it forms. That's part of vastus medialis as well. And this is where the blood supply comes and then through there. And then that goes through to the adductor hiatus, which you can't see because it's just all covered. So this is the thing when you start to layer things back and then it's all covered, that area, just go back there. So that groove bit there, that is all covered by your sartorius muscle over the top to protect it all. How cool is that? Brilliant. So there you go. So that was recap of the anterior compartment and then introducing the medial compartment as well, so you can see the relationship between the two. And we've started to introduce some of the blood supply. The nerve supply is a bit different to this region. We'll get to that when we come to it. So we've got the last few muscles next week, which will be the hamstring group. And then we'll start to move on to the blood supply and the nerve supply and finish off the knee. Cool. So welcome back, everybody. I hope you have... do you spell the name of the Australian bit? Yep. Bear with me a second. Yeah, sorry, I'm just reading a message there, and I should put it on the screen. There we go. How do you spell the name of the Australian peat? So it's Mallearis. Mallearis. It's either that or IS on the end. So Mallearis, I think is IS. Yeah. But he's brilliant. He does come to the UK to do courses. I did one of his courses about 5 years ago, and he's at the forefront of tendon rehab. The Australians do a great job with that. So him and Jill Cook. They've got some videos on YouTube. I think Pete's just launched a new course actually with updated research, which is all online as well. So that's really good. Really nice to listen to. Really explains everything really, really nicely. Cool. Good to see. Yeah, good to see you, Danny. So he's a really good guy for tendon stuff. Yeah. Gives you some good examples of how to progress rehab as well. So that's really useful. Cool. Have a good week. See you next Monday.